proceed. So let me begin by introducing the speakers for today. Dr. Smallwood is originally from Kentucky. He completed his medical school at University of Kentucky College of Medicine and his pediatric residency at Corsair Children's Hospital in Louisville, Kentucky. He completed his allergy immunology fellowship at Medical College of Georgia in Augusta in 2013. And Dr. Smallwood has been with Nemours since that time and has served as the chief of allergy immunology since 2015. He is loved by the patients. In addition, he is our pediatric liaison to the patient experience team. In his spare time, he likes to spend time at home with his wife and his 9-month-old son. Thank you, Dr. Smallwood, for joining us this morning. Our co-presenters are Dr. Edward Muiji. Dr. Edward Muiji is a PhD and is a member of Center of Pharmacogenomics and Translational Research at Nemours Children's Specialty Care in Jacksonville, Florida. He received his PhD in chemistry from University of Delaware and went on to complete several postdoctoral fellowships at Johns Hopkins School of Medicine. Dr. Muiji is currently working with Dr. Franciosi to develop the precision medicine algorithms for application to gastrointestinal disorders. He's trained as a chemist. He also has extensive experience in pharmacogenetics and pharmacogenomics and has published on pharmacogenetics of asthma controller therapy. Currently, he's focused on improving response rates to proton pump inhibitor therapy for eosinophilic esophagitis and has contributed in this field. And our next co-presenter is Dr. Jim Franciosi. He has extensive training and practice in pediatric gastroenterology at Children's Hospital of Philadelphia, Cincinnati Children's Hospital Center for Eosinophilic Disorders, and Nemours Children's Hospital. Currently, he serves as the Division Chief of Division of Gastroenterology, Hepatology, and Nutrition at Nemours. His team has written over 60 peer-reviewed publications and developed the first and only patient and family validated reported outcomes metrics called the PEDS QLE-OE module and the PEDS Pediatric Eosinophilic Esophagitis score that has determined genetic associations with PPI responsive eosinophilic esophagitis and has launched the transnasal esophagoscopy program with a mission to find ways to reduce the burden of eosinophilic esophagitis for children and teens through novel research and innovation. So please join me in welcoming our presenters for this morning's Grand Rounds of eosinophilic esophagitis. It takes a village. Gentlemen, take it away.
Well, thank you very much for that introduction, Shiva. I know that's a lot of people to have to introduce, so I really appreciate you doing that. So as he mentioned, the title of today's Grand Rounds is Eosinophilic Esophagitis, It Takes a Village. A few months ago, Dr. Franciosi approached me about his desire to build a multidisciplinary clinical center of excellence for EOE here at Nemours, and I was excited to join him. We know that effective care of EOE starts with a pediatrician or provider who is looking for and able to recognize the symptoms in their patients, allowing them to then involve a much larger team that often includes a gastroenterologist, a nutritionist, an allergist, and a psychologist at a minimum. Each of those providers also depends on a team of doctors performing translational research into eosinophilic esophagitis and its potential therapies, hence the village. To all of you listening to this talk, you're a part of the village too, so welcome. I have the distinct privilege of sharing my village and my time today with some individuals who are very passionate about this subject. While I will briefly touch on the history, the symptoms, and the immunology of EOE, it would take longer than a 1-hour Grand Rounds to provide a thorough, in-depth look at EOE. Instead, my primary goal for my portion of the talk is to give an overview on the role that my team in allergy immunology currently plays in the management of EOE patients. I'm joined today by Dr. Ed Muiji, who will discuss his research into precision medicine for eosinophilic esophagitis. And he will be followed by Dr. Jim Franciosi, who will close with a discussion on programmatic tertiary care for eosinophilic esophagitis, building a center of excellence. We have no financial disclosures for this talk, and the objectives are simply stated to identify the symptoms of eosinophilic esophagitis so you can make quick and appropriate referrals, and then be able to discuss with your patients the team of providers that they're going to be seeing as part of our multidisciplinary care and what each of us is able to do to help them. The symptoms of eosinophilic esophagitis as a unique diagnosis were first described in the 1970s. It would take another 20 years to identify and describe the role that foods play in this condition. 25 years later, we've continued to uncover more about the pathophysiology of EOE, but I feel that the definition on your screen captures the essence of what we understand EOE to be. It's chronic, it's related to interactions between the immune system and various antigens, and it's characterized by esophageal dysfunction caused by eosinophil predominant inflammation. This slide comes from a comprehensive talk about EOE by the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition. It demonstrates that as we travel through the GI tract, the presence of eosinophils does not always necessarily imply pathology. Eosinophils are commonly found in the mucosa and the submucosa of the stomach, the intestine, and the colon. However, a normal esophagus should not contain eosinophils. Esophageal eosinophils are always considered a hallmark of tissue inflammation. There are specific diagnostic criteria for EOE that we should be watching out for, and the first is symptoms related to esophageal dysfunction. Interestingly, the symptoms that a patient experiences often vary by age, becoming more severe as the patient gets older. As you can see from this slide, it may start with feeding dysfunction in a very small child, but by the time they reach their teenage years have progressed to food impaction. Because these symptoms are nonspecific, the diagnosis is often easily missed or delayed. In one retrospective study of 200 patients with symptomatic EOE, the median delay in diagnosis from the onset of symptoms was 6 years. As this slide shows, that can be the difference between a child experiencing abdominal pain and a child with food impaction. Increased duration of delay in the diagnosis was also associated with an increase in the presence of esophageal fibrosis and strictures. So early recognition and diagnosis of this condition is very important. The second diagnostic criteria is the presence of eosinophils, eosinophil predominant inflammation. And while the specific number may vary from one study to the next, in general, greater than 15 eosinophils per high power field is the accepted number. And lastly, exclusion of other causes. It's important to remember the presence of eosinophils in the esophagus is insufficient alone to make this diagnosis because eosinophils are associated with numerous processes in the body. In my clinic, it's not uncommon to have a patient tell me they were simply told eosinophils are allergy cells. While I understand the effort to try and simplify what eosinophils are, it's important as providers that we remember these cells can also be involved in neoplastic disorders, infectious diseases, endocrine disorders, rheumatologic disorders, and many other things. Even in the esophagus, the presence of eosinophils can be related to a number of diagnoses, including gastroesophageal reflux, celiac disease, Crohn's disease, and as you can tell from looking at this, these are all predominantly non-allergic disorders. So, we've laid out the diagnostic criteria and the possible presenting symptoms for pediatric patients with eosinophilic esophagitis. I told you I was going to go through that kind of quickly. So as the provider, you have now recognized the need for a referral. So what happens next? Well, at some point, your patient will likely arrive in our allergy and immunology clinic. So it's important to discuss what our role is in the evaluation and care of your patient. Some of you may wonder, why would an allergist and immunologist be involved in these patients in the first place? Well, while I know I have just finished discussing that eosinophils are more than just allergy cells, it still remains true that eosinophils are present in allergic processes. Moreover, as an immunologist, we know that EOE is mediated by a Th2 cell response. This is promoted by the presence of thymic stromal lymphopoietin, and esophageal biopsies in patients with EOE have been demonstrated to show an increase of TSLP. Additionally, Th2 cells also produce cytokines such as IL-5. This is a chief eosinophil growth and activation factor. This primes the eosinophils to have enhanced responsiveness to the chemokine eotaxin 3, which in turn serves in the recruitment of further eosinophils. Th2 cells also produce IL-13, which triggers resident cells such as esophageal epithelial cells to further produce eotaxin 3. An allergist and immunologist is also involved because we know that the majority of patients with eosinophilic gastrointestinal disorders also have comorbid atopic diagnoses, including allergic rhinitis, asthma, atopic dermatitis, and food allergies. In fact, food allergies alone occur in up to 20% of patients with EOE, compared to approximately 6% of the general population. This is likely why it was initially stated food allergies were the probable cause for eosinophilic esophagitis. I still hear in my clinic patients who've been told, oh, your EOE is caused by food allergies. However, we now know that IgE is felt to play a relatively minor role in EOE, and that these atopic conditions are comorbid, correlative at best, but not necessarily causative. It's really important to understand that as an allergist, when we use the term allergy, at least here in the United States, we are talking about type 1 hypersensitivity disorders, those mediated by IgE. Now, understand that just because the patient is not allergic to a food doesn't mean that there are non-allergic ways that foods could still bother them. However, this should help to highlight and explain the current decreased reliance on broad skin testing or blood testing for food allergens in this patient population. We'll discuss that more in just a moment. Even clinically, the symptoms of EOE do not behave like an IgE-mediated disorder. Onset of this disease is delayed. Symptoms are localized to the GI tract, triggering an inflammatory response from infiltration of the GI mucosa, whereas an anaphylactic reaction rarely remains localized and is acute in onset. Therefore, rather than labeling EOE as being caused by food allergens, I find it more appropriate to use the term food antigens. This is also less confusing for our patient population. So let's look at some of the testing that's available in my office and its utility in the treatment or diagnosis and evaluation of EOE. So skin testing. When I began working at Nemours 7 years ago, it was common that patients with EOE underwent broad allergy testing to a variety of foods, trying to look for possible allergens that might be playing a role in their symptoms. Over time, the attitude around the utility of skin testing, however, has shifted. A series of 3 studies compared the effectiveness of skin prick testing versus food elimination with sequential reintroduction and biopsy. As you can see, only 5 to 15% of patients had their food antigens correctly identified through broad skin testing. Studies have demonstrated that for patients with EOE, food elimination can help to reduce the presence of eosinophils, and they can return upon introduction of specific foods. However, because this is not mediated by IgE, broad skin testing in the hopes of just determining all of the foods that are causing EOE is not recommended. Similarly, broad blood testing to look for potential trigger foods also has resulted in few foods being correctly identified. One study found that the success of blood testing was no more effective in reducing the presence of esophageal eosinophils than a 6-food elimination diet, in which the patient just innately removed milk, egg, wheat, soy, peanuts and tree nuts, and seafood, which would be fish and shellfish. Now, technically, I know that constitutes 8 food groups, but this is often referred to as a 6-food elimination diet. And these are the most common foods identified to be associated with EOE. These are also very common food allergens. In fact, because of false positive test results from specific IgE testing, this study showed dietary eliminations based solely off of specific IgE testing were often overly restrictive on patients. Therefore, specific IgE testing to determine foods to eliminate from the diet is also not currently recommended. What about patch testing? Patch testing has been used to look for a possible late phase reaction due to type 4 hypersensitivity to various foods. I will admit this testing is time intensive. It requires the patients to wear stickers filled with various foods on their back anywhere from 48 to 72 hours before returning to our office to look for potential inflammation. We initially performed these when I first started working at Nemours, and I remember having around 20 different jars of baby food in our back room to be able to put onto these stickers. Suffice it to say, having to wear baby food on your back for 3 to 4 days, especially as a teenager, is not really a driver of patient satisfaction, especially when patch testing has been shown to have poor negative predictive value. As a result, patch testing by itself is not typically recommended. In my experience, we perform between 40 to 50 of these in our office without a single positive response, and then just continue doing them at that time. In my research for this talk, I was able to come across one study that did demonstrate some improvement in predicting foods with a combination of both patch and skin prick testing. However, this combination was absolutely no better than the resolution that was obtained with the 6-food elimination diet we just talked about. And ultimately, for most allergists, patch testing has fallen by the wayside. There is clinical interest in the role that environmental allergens may play in eosinophilic esophagitis. As previously mentioned, it's common for patients with EOE to also have comorbid allergic rhinitis. Interestingly, it's also been reported by some patients that their symptoms of EOE seem to have seasonal variations, along with increases in their allergic rhinitis symptoms. This has also been supported by seasonal variation noted in the amount of eosinophils on esophageal biopsies. In fact, at one time, aeroallergens were considered the predominant cause of EOE in adults, and this remained until studies showed that elimination diets were successful in many adult patients as well. Ultimately, it's unclear at this time if the seasonal increase in esophageal eosinophilia and associated symptoms implies causation, and if it does, is this related to the unintentional swallowing of inhaled allergens such as pollens or dust mites? Or could it possibly be related to increased postnasal drainage? This is why the role of environmental allergens remains somewhat controversial and definitely requires more study. Over the last decade, there's been increasing interest in the role that the antibody subclass IgG4 may play in a variety of gastrointestinal disorders. In EOE patients specifically, increased IgG4 has been noted to 2 of the more common foods associated with this disorder, milk and gluten. However, at this time, the exact role that IgG4 might play, if any, is unclear. Rather than serving as a marker of allergy, intolerance, or dietary inflammation, as is sometimes purported, it's becoming clear that IgG4 is more likely a marker of previous exposure, but is not predictive of sensitivity or likelihood of reaction if the patient were to be exposed. In fact, it may even demonstrate resolution of a previous food allergy. As a result, IgG4 testing is not currently recommended in the evaluation of EOE, food allergy, or other gastrointestinal disorders at this time. So I know I went through basically all the testing that we would normally do in our office and just explained that this is not necessarily useful in the broad testing and determination of foods associated with EOE, and I stand by that. So in closing, then we return to the question, so what in the world then is the role of the allergist and immunologist in the evaluation and care of patients with eosinophilic esophagitis? Well, first, I think that we play an important role in the provision of education to our patients and their families. In some cases, we are the first subspecialist that a patient with EOE ever sees. Therefore, the burden falls to us to help them better understand their diagnosis, as well as their need for a multidisciplinary care team. We also need to be prepared to educate the family around the utility or lack thereof in currently allergy testing methods in helping to diagnose food triggers in their children. While broad allergy testing is not recommended to try to determine potential food triggers, I would suggest that it can be highly useful for patients who come to our office on significantly restricted diets. Someone has already told them, well, you need to cut out all of these foods well beyond that of a 6-food elimination diet in order for your symptoms to get better. And they come to our office and we can use testing to help demonstrate the absence of allergy to many of those foods, especially the less common food antigens, and to reintroduce those foods to their diet. Additionally, patients who have previously eliminated foods because of EOE could undergo allergy testing prior to their eventual reintroduction to ensure that the patient has not become allergic to those foods in their absence. This is particularly helpful in patients who have eliminated the top 8 allergens, which are again consistent with those 6-food elimination diets that we talked about earlier. Finally, we recognize the increase in comorbid atopic conditions for patients with EOE. And I feel that we remain a vital part of this village by keeping those controlled while the rest of the members of our village continue to do their part. So that will conclude my portion of this talk. If you'll give me just a moment, we will pass the ball to Dr. Ed Muji, who will then talk about the role of research into eosinophilic esophagitis. Thank you very much for your time today. All right, Ed, I think you should be on.
Thank you, Dr. Smallwood. Hello and good morning. My name is Ed Muji, and I'm a research scientist with the Center for Pharmacogenomics and Translational Research in Jacksonville, Florida. The title of my talk today is Precision Medicine for Eosinophilic Esophagitis. I have no conflicts of interest to declare with any of the information I'll be presenting today. Proton pump inhibitors are used extensively in children to treat eosinophilic esophagitis. Despite their popularity for treatment of eosinophilic esophagitis, PPIs can fail in up to 60 to 70% of the children that receive them. Clearly, there's an immediate need to improve response rates to PPI therapy for EOE in children. One of the reasons that PPIs can fail has to do with pharmacogenetics. Individual pharmacogenetics is determined by individual genetic variation in the genes that are responsible for producing the enzymes that regulate absorption, distribution, metabolism, and elimination of therapeutic drugs in the body. Individual differences in pharmacogenetics can lead to individual differences in drug pharmacokinetics, which in turn can lead to individual differences in drug pharmacodynamics or outcomes. CYP2C19 is the enzyme that's primarily responsible for metabolizing proton pump inhibitors in humans. There are several well-characterized variants in CYP2C19 that influence its activity, including the star 17 variant, which leads to an increased function of CYP2C19. Individuals that carry this variant have a reduced plasma concentration of PPI relative to individuals that carry the normal variant. This results in a reduced activity for acid suppression. Now imagine for a moment that we knew that an individual carried the CYP2C19 variants before we began therapy. Theoretically, what we could do is increase the dose of the drug that we give to these individuals, which theoretically would normalize their pharmacokinetics and result in normalized pharmacodynamics or outcomes. The process of varying therapy based on individual differences is known as precision medicine. The overarching goal of our program is to improve PPI therapy outcomes for EOE children through precision medicine. Now, you may be wondering why PPIs are effective at treating EOE since they are anti-acid drugs. And many of the EOE patients have normal pH probe acid profiles, and numerous studies have failed to demonstrate an association between reflux severity and inflammation in EOE. So how is it that PPIs are effective for treating EOE? Well, this has been the subject of considerable research within the field. In 2019, a group published a study that identified omeprazole as having an activity which blocks the STAT6 binding to the promoter of an inflammatory gene in eosinophilic esophagitis cells. The reason this is important is that STAT6 is a transcriptional enhancer of a class of pro-inflammatory genes that are upregulated in the epithelium of EOE patients. One of the genes that STAT6 enhances transcription of is CCL26, which codes for eotaxin 3. Eotaxin 3 is the major chemotactic factor in EOE patients and recruits eosinophils to the esophageal tissue. So this was a very impressive and elegant work in which they were able to show that omeprazole inhibits the chromatin remodeling, which is necessary for STAT6 binding to the promoters of these pro-inflammatory genes. And they were able to demonstrate a dose-dependent decrease in the expression of eotaxin 3 in the eosinophilic esophagitis cells. And this is important for us because it suggests that STAT6 may be a pharmacogenetic target or pharmacogenomic target for association with outcomes to PPI therapy in EOE patients. This is about the point at which we entered the field. One of our primary hypotheses was that the outcome of PPI therapy for EOE will associate with CYP2C19 metabolizer phenotype. So as I mentioned on the pharmacogenetic slide, CYP2C19 has an increased function variant known as star17. Individuals that carry this variant are referred to as extensive metabolizers, or EMs. In these individuals, they have reduced plasma concentrations of the drug due to increased rate of metabolism, and we predict that this reduced plasma concentration will lead to a reduction in the ability of PPIs to inhibit transcriptional activation of the CCL26 gene, leading to increased levels of eosinophils prior to initiation of PPI therapy. And we predict that these individuals will also fail to respond as well to PPI therapy as individuals who have normal variants of their CYP2C19 gene. In essence, what this will look like is that these individuals are underdosed for PPI. The second hypothesis has to do with STAT6. In the literature, there are descriptions of activating and inactivating variants of STAT6. We predicted that these variants would associate with outcome of PPI therapy by regulating the basal inflammatory response in individuals who carry them. For example, individuals that carry copies of a gene which is inactivating for STAT6 would potentially assemble fewer functional transcription complexes on the inflammatory genes, resulting in a lower level of eotaxin-3 production and lower numbers of eosinophils being recruited to the esophagus. Conversely, individuals that had activating mutations in STAT6 we predicted would assemble more functional transcription complexes, ultimately resulting in more eosinophils being recruited to the esophagus. We predicted that these different variants would associate with response to PPI therapy. About this time, a group in Madrid, Spain, published a study in which they found a high prevalence of response to proton pump inhibitor treatment in children with esophageal eosinophilia. They were able to demonstrate the up to 70% response rate to proton pump inhibitors in individuals that were treated with a high dose of esomeprazole, which was equivalent to 2 mg per kilogram per day. We contacted this group to initiate a collaboration. This is a schematic of the trial that the Madrid group conducted. It was composed of 2 phases. In the first phase, they had an 8-week high-dose esomeprazole trial. And individuals who responded to this high-dose phase were then stepped down to a low-dose maintenance phase and were monitored for a year. So the children that they recruited were between 2 and 16 years old, and they had at least one symptom related to esophageal dysfunction. They were recruited to the 8-week high-dose PPI therapy phase if they had greater than or equal to 15 eosinophils per high-powered microscope field on their baseline esophageal biopsy, and that corresponded to 92 patients in this particular study. Then they performed a second biopsy after 8 weeks of high-dose PPI therapy, and individuals who responded had less than 15 eosinophils per high-powered microscope field, represented 62% of the population, whereas individuals who didn't respond represented 38% of the population. A sub-analysis of the individuals who responded revealed that overall 41% exhibited complete response, which is defined as having less than or equal to 5 eosinophils per high-powered microscope field. So the first thing we did is we looked at the data from these patients to see if there was a relationship between the dose that they received and the probability of responding to PPI therapy. And we found this very nice relationship. although it failed to reach significance in this population, the results tended to indicate that the probability of responding to PPI therapy increased almost 7.7-fold as the dose of PPI increased by 1 mg per kilogram per day. So this suggested that we're on the right track. The next thing we looked at were the eosinophil counts that were present in esophageal biopsies, both at the baseline endoscopy and at the endoscopy after 8 weeks of therapy. While we didn't see associations with the CYP2C19 variant, we did see significant associations with several variants in STAT6. In particular, individuals who carried 2 copies of STAT6 variants 324011 exhibited a 1.5-fold increase in esophageal counts at baseline relative to individuals who did not carry any copies of this variant. On the other hand, individuals that carried copies of 1059513 STAT6 variant exhibited decreased counts of eosinophils at the end of the 8-week relative to individuals who didn't carry any copies of this particular variant. So this is very interesting because now we have a STAT6 variant which predicts failure of PPI, which could predict failure of PPI therapy, and a STAT6 variant which could predict response to PPI therapy. The next thing we did is we looked at whether or not these genetic variants were predictors of response to therapy using logistic regression modeling. When we examined the CYP2C19 *17 variant in the full cohort, we found that the odds of failure went in the right direction. However, the results were not significant for this particular cohort. To make a long story short, if we eliminated the individuals that received the bottom quarter doses, so that's the lowest quarter of doses, and the highest upper quarter of doses, and just examined the 50% of the individuals that received in the middle range of doses, we then saw a significant relationship between carriage of CYP2C19 *17 variant and failure of proton pump inhibitor therapy. In particular, in these individuals, if they carried 1 or 2 copies of this variant, they were 7.7-fold more likely to fail proton pump inhibitor therapy than individuals who didn't carry this particular variant. For comparison, you can see that the individuals that received the bottom quarter and the top quarter of doses had no relationship at all to outcome and carriage of CYP2C19 *17 variant. Next, we turned our attention to the STAT6 variants. We examined the 2 STAT6 variants I discussed previously in the full cohort. We didn't see any relationship with 324011 an outcome with PPI therapy that was significant. However, we did see a significant association between 1059513, which predicted almost a 6-fold increase in odds of responding to PPI therapy in individuals who carried 1 or 2 copies of this variant, although the confidence intervals for this analysis are fairly large. Finally, what we did is we examined 324011 in a model that also contained a term for the CYP2C19 variant, and we found that individuals who carried 324011 were more likely to fail to completely respond to PPI therapy when the gain of function variant is also included in the model. The significant interaction term between these 2 factors in this model suggests that there's a synergy between them, which combines to increase the odds significantly that individuals that carry both of these genetic variants, one in STAT6 and one in CYP2C19, will fail to respond to PPI therapy. So the conclusions from the 8-week phase study are that carriage of CYP2C19 *17 variant associates with failure of PPI therapy for EOE within a specific dose range that corresponded to 1.54 to 2.05 mg per kilogram per day in this particular study. Carriage of STAT6 variant RS1059513 increases the odds of responding to PPI therapy. And STAT6 and 324011 and CYP2C19*17 synergize to increase the odds of a therapy failure. And this is the first example of a pharmacokinetic pharmacodynamic interaction for EOE. The results for the 8-week phase study were published in 2018 in the Journal of Pediatric Gastroenterology and Nutrition. Next, we turned our analysis to the PPI maintenance phase. So individuals who responded to the 8-week phase were put on a low-dose maintenance phase and followed for a year. At the end of the year, they had a third biopsy, and 67% of the patients responded, having eosinophil counts less than 15 per high-powered microscope field, and 33% relapsed to EOE during this period. Our hypothesis was that the outcome of PPI maintenance phase therapy for EOE will associate with carriage of STAT6 variant 324011. This is a fancy way of presenting the density of eosinophil counts that were obtained in these individuals. These are violin plots. The top panel represents the counts at the end of the maintenance phase, and the bottom panel represents the difference in the counts between the beginning and end of maintenance phase. And what you can see is a dramatic difference in the distribution profile of eosinophil counts between individuals who carried RS324011 and individuals who didn't carry RS324011. The take-home message from this slide is that individuals who carried 324011 had higher eosinophil counts at the end of the maintenance phase, and the median of the distribution of eosinophil counts was skewed to higher values in these individuals, resulting in a significant difference between individuals who did not carry copies of RS324011. Again, turning to logistic regression, we found that the carriage of RS324011 predicted individuals who would have an increased odds of failing PPI therapy. In this particular analysis, individuals who carry one or more copies of RS324011 have a 2.7-fold increased odds of failing to respond to remain in remission of EOE during the maintenance phase. And they have a 3.6-fold increased odds of failing to remain in complete remission during the maintenance phase. Overall, if you look at the influence of RS324011 on failure of PPI therapy in both phases combined, again, carriage of RS324011 predicts a 2.8-fold odds of failing at some point during both phases. So the take-home message from this study is that pediatric patients who initially respond to PPI therapy and carry STAT6 variants RS324011 are at increased risk of relapse after 1 year of PPI maintenance therapy. This work was recently published in Clinical Gastroenterology and Hepatology. Future directions for our program will be to build a network of national and international collaborators to share patients and data. We intend to develop an informatics model that predicts who will and will not respond to PPI therapy for EOE. And eventually, we hope to institute a precision medicine clinical trial of PPI for EOE that's guided by a physiology-based PK/PD model and informed by our informatics model. I'd like to acknowledge and thank all the individuals on this slide, especially Dr. Franciosi and Mary Lee, and the Nemours Foundation for their continued funding. Thank you very much for your attention and the opportunity to present some of our research today.
Thank you, Dr. Muji and Smallwood, for your outstanding presentations. It's really an honor and a privilege to work with you. And I would like to thank the organizers of the Grand Rounds for the opportunity to present today. So what we're going to do now is really talk about how this all comes together. How do you align the wonderful basic and translational science that you've heard with the clinical development into a particular area? So this is what we talk about when we mention programmatic tertiary care. And we're going to be focusing today on eosinophilic esophagitis, but you can also think about in your respective areas how this could come together for you and your programs. This is my conflict of interest. This is a questionnaire that we developed for eosinophilic esophagitis. In particular, we're not going to be talking about this today. I wanted to first start with our strategic pillars and foundational imperatives from Nemours. Overall, calling your attention to the right hand of this slide in terms of academic preeminence, clinical preeminence, national reputation and impact, and the voice of the child and family, these are areas to focus on in the next components of our talk. Specifically, what is a tertiary center of excellence? Well, I'll point to our good friend Will Farrell when he talks about strategery. There is strategery involved when trying to align these various components in a positive direction and outcome. So how do we get to excellence? How do we point in that area? In terms of what is a center of excellence, it's interesting to note that a center of excellence isn't specific to medicine, and that the definitions of a center of excellence within medicine can vary greatly depending on the disease and organization that defines that. Broadly, when we look at what JAMA describes as a center of excellence is a team of highly skilled experts involved in research and innovation to advance the field. And that's what we're talking about today for eosinophilic esophagitis. Specifically, multidisciplinary subspecialty clinical care, quality improvement, telehealth, innovation, specifically unique clinical services, research, partnership with patients and families, and national reputation. So this is a jigsaw puzzle in terms of how you get these components to come together, specifically with regards to clinical care, innovation, research, and then a national reputation. Nemours does have the beginnings of centers of excellence types of programs, what are called luminary programs for Nemours. Specifically, these are unique capabilities that can attract national referral patterns and aligns with Alfred I. DuPont's wishes that we would provide care not readily available elsewhere. This builds on the national reputation of Nemours, and as examples at Alfred I. DuPont Hospital for Children in Delaware are the skeletal dysplasia program and their epilepsy programs currently. For us, when we talk about multidisciplinary care, there's a lot of folks involved in this. Specifically, you can see Dr. Ed Muji there, Dr. Haddad, one of our wonderful gastroenterologists, Dr. Smallwood, who you heard speak today, was excellent. Tanya Ruiz, one of our nurses, who's been instrumental in our transnasal esophagoscopy program. Dr. Beth Long, our outstanding psychologist. Amy Melano, our outstanding dietitian. Kim Howard, our wonderful feeding therapist. And Shannon Henry, our outstanding research coordinator. It also takes a great many people in addition to those folks that I just mentioned. It's getting close to Halloween, and our GI team is very excited about that. And these efforts definitely take all of the strong work of the many components and people that it takes to develop GI and multidisciplinary care for eosinophilic esophagitis. At the bottom is just a note and a shout out to our patients and families, for which none of these efforts would be possible without their involvement, and it is really for them, for the patients and families, to improve the outcomes. We've all now had a lot of experience with telehealth over the past few months. So how does that all come together? Well, telehealth has the unique opportunity for us really to expand our access and vision to a wider variety of patients and catchment area. It allows us to provide subspecialty tertiary care and then follow-ups to patients in their homes. So we had the honor and opportunity to provide this nationally recently in terms of the Nemours experience. Then quality improvement. How does that come together? So when we look at the Nemours Children's Hospital here in Orlando, it's important to recognize that we are all part of the Nemours Children's Health System. And quality improvement really involves all of the campuses in Orlando, Jacksonville, Pensacola, and the Delaware Valley. We, in aggregate, are a very large health system for children. Specifically for eosinophilic esophagitis, we have a Nemours cross-campus clinical collaboration, a clinical standard work. So all of the effort and energy we place towards the electronic medical record, how can we use that to really align our clinical outcomes for the best possible care for children and also research development? Well, we can develop smart forms for eosinophilic esophagitis, in particular, identifying the type of eosinophilic esophagitis, nutritional components, symptoms, endoscopic reports, and other outcome measures. And from there, across the enterprise, this is something that we can measure. So for the various providers, are we using the forms effectively? And this all can translate into improved outcomes and care for the children that we serve. Next, innovation. So unique clinical services. What makes this area and your particular program really unique? Well, we're pleased to report that we have been successfully launching an unsedated transnasal endoscopy esophagoscopy program. So yes, this is one of our patients that is undergoing no sedation at all for anesthesia, etc. And we're able to do an esophagoscopy or a camera study through the nose that is actually looking at the esophagus. We had our wonderful volunteers among our staff when we first started, and now we've had the opportunity to bring this to over 30 children with eosinophilic esophagitis, and we continue to grow and develop. In particular, for unsedated transnasal endoscopy, or TNE, once again, this does not involve general anesthesia. Unlike a standard GI endoscopy, there's no IV needles that are needed. It takes about an hour from coming in to going home, and the procedure takes 10 to 15 minutes to perform. It limits the amount of time that they don't have to eat or drink. And the cost, the value of this service is significant in terms of the care. Next, we are excited that we'll be bringing another technology called EndoFlip that is the newest area in terms of assessing esophageal motility and looking at esophageal strictures that can be part of eosinophilic esophagitis. So how can you really optimize stricture assessment and dilations? And that's with this new technology called EndoFlip. Next, our vision is to have point-of-care PPI medication genetic testing. So at the bedside, this tiny little cube in clinic, you could envision that you could take a cheek swab and you could be able to predict the CYP2C19 or in the future STAT6 genotype and be able to predict which patients may or may not respond to PPI therapy and the dosing of therapy. From there, in looking at research, it is important to note that industry-sponsored research and clinical trials are an important component for a successful program. For eosinophilic esophagitis, the Food and Drug Administration has recently put out guidelines for developing drugs for treatment for this condition. In particular, this is talking about outcomes and what are the best outcomes. So if you can really integrate those outcomes into clinical care, you're well on your way to being good candidates for industry-sponsored research and also investigator-sponsored research. In terms of GI precision medicine, which Dr. Muji discussed, in terms of PPI medications, when we look at pharmacogenetics, and then we look at pharmacokinetics, or what the drug does to the body, and then we look at pharmacodynamics, in particular, the pharmacokinetics is what the body is doing to the drug, and the pharmacodynamics is what the drug is doing to the body. So that's the outcomes, the good outcomes of healing the inflammation or swelling that is related to eosinophilic esophagitis and other conditions, and then making sure that there's not poor outcomes in terms of infections and so forth. So as we've mentioned, one of our first areas led with the pioneering work of Dr. John Lima was around CYP2C19. And now we're exploring other candidates as well. But there are other areas. We are also involved in an investigator-initiated online clinical trial. So many may have heard that for inflammatory bowel disease, there's been successful intervention with a specific carbohydrate diet that eliminates inflammation to a degree for some children with inflammatory bowel disease. We also asked the question about food additives and preservatives, which have been a concern by the FDA and others that this may be creating inflammation. And so we asked the question, are food additives contributing to some of the inflammation involved with eosinophilic esophagitis? And so this is our free trial or food additive removal diet for eosinophilic esophagitis. We've been able to promote this nationally with a IRB-approved national online dietary clinical trial for eosinophilic esophagitis, and have a web page for that trial. And next, as we look at this, it's also important to recognize that this is not possible without successful partnership with patients and families. Certainly in terms of the patient and family experience, we want to make sure that that experience is excellent and provides the highest level of care. We don't want to say that this is like gastroenteritis. Rather, we want to make sure that the patients and families have an outstanding experience that is not unlike fireworks. In particular, for us, we are partnering with our patients and families in terms of how to continue to improve our outcomes and care. So one of our patients from Jacksonville is helping us to improve our transnasal esophagoscopy program. Next, in terms of national reputation. So we all know that Orlando is nationally and internationally recognized for many wonderful things in the area. How do we translate that to Nemours Children's Hospital and the Nemours Children's Health System? Once again, in aggregate, this is a large multi-site children's health system, caring for many children and employing many physicians and researchers. For us, that is about promoting and educating our peers. So we've had the privilege to talk about vomiting at the American Academy of Pediatrics seminars in 2018, and vomiting can be one of the common presentations for eosinophilic esophagitis. We've also nationally discussed about telehealth and how to integrate that into a pediatric GI practice. This is one of the areas that, in terms of eosinophilic esophagitis, we can capture more broadly in terms of patients. In addition, we've talked about pediatric GI T&E program and the steps for a successful business plan. Once again, this was a national presentation to a large audience of pediatric gastroenterologists. We are also looking at a national consortium at how to excel the transnasal research and education acceleration. So the PEDS GI T-REX consortium is in process of being developed. From there, it is about publications and how we are able to communicate effectively our scientific progress and development. So looking at STAT6 variants with eosinophilic esophagitis, developing pharmacogenomic consortium guidelines for PPIs, and also expanding our telehealth services, during the era of COVID-19 and beyond. From there, we are implementing a website which we're excited to launch in the next few months that brings together our patients and families, explains the role of our team members and their bios, explains the clinical trials and studies that we can promote, and also will have a portal that's HIPAA protected and IRB approved for researchers to integrate the clinical outcomes with our scientific discoveries. In summary, eosinophilic esophagitis care takes a specialized multidisciplinary team. The role of the allergist is to provide education, help in dietary management, and treat comorbid atopic conditions. Common genetic variants in STAT6 and CYP2C19 predict poor response to PPI therapy for EOE and may be useful in developing a precision medicine approach for EOE therapy. Programmatic tertiary care centers of excellence can align the Nemours strategic pillars and foundational imperatives around specific conditions. We are excited that a tertiary center of excellence is coming to NCH for eosinophilic esophagitis. I would like to acknowledge our wonderful group of investigators for which the scientific discoveries would not have been possible without their efforts. And I also would like to acknowledge our clinical and operations teams, as well as our patient and family care partners, again, without whose efforts these work would not be possible. Once again, thank you, and thank you for this opportunity. With that, we can entertain some questions.
So I've got our chat pulled up here, and Dr. Moujji, if I can have you come off of mute as well, we'll be able to tackle it. I've got one question currently, but if we have any other questions, please just add those in the chat box. The first question that we have is, what is considered long-term PPI use, and what is the history of adverse effects of such administration in children and adults?
So long-term PPI use would be considered the maintenance phase of PPI therapy for EOE, so up to and over a year. It's recently become evident that due to the acid suppressive nature of PPI therapy, there can be an increase in bacterial load in the gastric compartment, which can then be refluxed into the lungs. So there is evidence, and John Lima and actually Dr. Franciosi published on this previously, suggesting that individuals who are poor metabolizers of PPIs can experience an increase in respiratory infections.
Very good. And the second question is, please give us your expert opinion on the role of oral budesonide.
Sure, I can take that one, and thank you for the question. So it is important to note that today there are several different therapies available for eosinophilic esophagitis. One is dietary elimination that Dr. Smallwood discussed. The next is PPI therapy that Dr. Moujji discussed. And the third key component that is a standard of care currently is swallowed steroids. So one swallowed therapy is the fluticasone. The other is oral viscous budesonide, where patients take the same drugs that we use for asthma, and they mix that with something, typically either Eocate Nutra or honey or some other thickener, and they actually swallow that, and that coats the esophagus. The benefit of those medications is that it works. It works in over 86% of patients. The downside is that you're talking about chronic long-term medication. So once you take away that swallowed steroid medication, the disease will come right back. So we do try and work, if people choose that therapy, then we do try and work on reducing the dose as much as possible. But we have seen that when you try and eliminate that medication altogether, the disease will come right back. The last area that we didn't discuss is about new pharmacologic drugs that are coming. So there are different specific blockers that are coming that are under investigation in industry-sponsored clinical trials.
We have another question that just came up. Is there a role of mepolizumab in EOE in children? So Jim, I think this kind of dovetails off of what you were just talking about.
Yeah, so that, thank you. So that is an excellent question. And I would say that for right now, maybe, right? So that we, there are active clinical trials that are ongoing to answer that question. And I think that there is significant interest and energy in biologic therapy for eosinophilic esophagitis. I think it does remain to be determined whether or not these drugs are effective. And effectiveness is actually in several different categories. Does it improve their symptoms? Does it improve the endoscopic visualization of the esophagus? Does it improve their eosinophil counts in the tissue? And is it free from severe side effects and so forth? So I think that those questions are still ongoing and remain to be determined whether or not that may be an effective therapy.
Very good. Any other questions? All right. Well, that's all I see. Well, again, thank you everyone for attending Grand Rounds this morning. Again, my sincere gratitude to Dr. Muji and Dr. Franciosi for presenting with me. This was fantastic, and I'm so excited to be a part of the team with you. So thank you to everyone. Have a great day.
Thank you, everyone.
Thank you.